Good afternoon, everybody, and welcome to this afternoon's public session of the West Yorkshire Partnership Board. My name's Tim Swift. I'm the chair of the Partnership Board and also a councillor and chair of the Health and Wellbeing Board in Calderdale. So this afternoon's meeting, particularly Partnership Board, as always, is about our shared work on joining up services and support and investing in ways to meet the current and future health and wellbeing needs of people in West Yorkshire. Today's agenda shortened because we had a development session to talk about how these arrangements are going to need to change as the Integrated Care Board changes and the structures for health change. But particularly includes an update from Rob, our partnership lead, a report on patient and public voice, and a focus on our ambition to strengthen the local economy, with a focus on NHS England Health and Growth Accelerator and Working Well. As part of the welcoming, I think most people on the call will be aware, but it's important to record that our Chief Executive, Rob Webster, has recently announced that he will be stepping down from this role in the future. This isn't Rob's last meeting of the Partnership Board, so there'll be other opportunities to pay tribute to his work, but I did just sort of want to briefly mention that and say how much Rob's contribution to the partnership and to health and working together in West Yorkshire is appreciated. I just remind people, as always, to mute your microphones when you're not presenting or speaking. When you are presenting and speaking, to introduce yourself. I even remembered to do that myself today, and use the raise hand function on the chat to let me know if you want to contribute at any point. We don't have any questions or public delegations today. Again, to remind people watching online that facility is always there in meetings. We'd always welcome public questions and delegations. Item 3 is to remind members to make any specific declarations of interest they feel to for the item, but also again to remind people both in the meeting and online that we have a shared register of interest based on the declarations that we all make to our individual organisations, as well as any collective declarations that we need to make. Item 4 is the minutes of the last meeting and the action log. And can I just ask, first of all, if there are any points of accuracy regarding the minutes? I'm not seeing any, so in that case, can I take it that we're happy to approve those minutes as the correct record, that there's nobody who dissents from that? Thank you very much. So those are approved. And then on to the action log, just to check, is there any points to be highlighted on the action log, please? I think the two that picked up is that the information related to mental health in schools, which was an action from 325, that information has now been shared. And I've just realised I've been pushing through this so quickly that somewhere along here I forgot to mention any apologies for absence. There is quite a lengthy list of apologies. Laura, do we need to read those into the record, or can they just be minuted?
I think we'll just minute them, Councillor Swift. As you say, there's quite a lengthy list of deputies and apologies. So yes, we'll just minute those. Thank you.
Thank you very much. Thank you very much, Laura. So in that case, then, if there's nothing else on matters arising, I'm going to go on to item 5 and ask Rob to introduce his update paper that's already been circulated. So Rob, over to you.
Thank you, Chair. Hello, everybody. My name is Rob. I'm the Chief Exec. Thank you for those kind words as well, Councillor Swift. This won't be my last meeting, so you can say lots of nice things about me next time, as long as I don't do anything bad. Thank you for that. Everyone's got the report, and it includes a copy of the Chief Exec's report to the Integrated Care Board as well, to give some detail on some of the areas upon which we're focused. Since the report was published a week ago, there have been 2 or 3 things that are useful to update the Partnership Board on as we go through. So I just wanted to emphasise a couple of things in the report. and to give the partnership board some updates on some material points which will be of interest. So the report really sets out and reminds us all that this partnership board is a statutory board and one which has been built on a set of relationships and collective working that's required if we're to deliver the strategy that we want to deliver for the people of West Yorkshire to improve the outcomes for them and to address inequalities, unwarranted variation, and ensure that we deliver value for money for the taxpayer, including the social and economic return on our investments. And in that space, we are in a position where this version of the partnership board won't be required under statute in the future. And one of the things that we've been looking at quite carefully is what do we need to do then as a partnership? Where do we add value in this context, given since we were created, we now have a mayoral combined authority and changes to the rest of the structure of the health and employment system. So there are reflections around that throughout the period plan and throughout the conversations today. And I think we just need to know that there's work and conversations going on to consider what sort of partnership we want at this level in West Yorkshire and how that builds upon, as it always has done, this principle of subsidiarity and what happens in our health and wellbeing boards, in our fellow places, what happens in neighbourhoods where people receive the vast majority of their care, where joining up services are something that they want, and for those services to help improve outcomes for them and be very personalised, and really to promote a culture where we build on the strengths that people have, a strength-based culture, an asset-based culture rather than a deficit-based culture. Within the paper, you'll see there's an update on the ICB's programme of reductions. And just to remind partnership board members that there are 4 real levels of change going on in the health and care system at the moment. So we've got national changes, and in the last week, the Department of Health has published its integration plans with NHS England. And the expectation that there will be consultation in October, the future shape of NHS, DHSC and NHS England, with things being in place from 2027. It's subject to legislation, but still a commitment to getting that legislation made and introduced by April 2027, which would then signal the changes to the requirements of the partnership board. So that reduced Department of Health and Social Care with regions of NHS England probably going at a faster pace than October for their consultations, sets out the national changes. At a regional level within NHS England, there are 8 work streams looking at how things like strategic workforce, something that we're all interested in because of the skills agenda, the digital agenda, again, a big part of our economy going forward, how we are held to account by the Department of NHS England as a regulator in the future, etc. Those 8 work streams we're fully involved in, and they give us some clarity around where some things will be done in the future, but not for everything. The 3rd level is the ICB level, the West Yorkshire level, and we've currently given to over 250 staff the go-ahead for voluntary redundancy under our first voluntary redundancy scheme. The second voluntary redundancy scheme opened on the 30th of January last Friday, and we expect to have some more people applying for that scheme, with us seeing a 42% reduction in the overall posts in the organisation by the 1st of April. So substantial change, which then relies on the 4th level of change, which is really what goes on in places with providers. And the report highlights, and I'm very grateful for, the work that's going on with our providers in each of our places to create partnerships which will deliver the joined up care, which will sit around the table with local councils, VCSE representatives and others to make sure that we've got joined up services which are supporting the health and wellbeing strategies of those places. So it's worth reminding ourselves that all of that's going on and it has to make sense. In parallel, the changes to local government may have less of an impact in some ways in West Yorkshire because of our uppity local authority structures, but do confer more responsibility and accountability on the mayor around the public's health. So those wider issues that we're very seized upon here around the economy, transport, and so on. So that's the first thing I just want to reinforce from the paper. The second is that since the paper was written, we've had announced the outcome of the ballot of resident doctors, formerly known as junior doctors, into whether they have the mandate to continue to take industrial action. And it's been announced that I think on a 52% turnout, 93% of people favoured a continuation of industrial action. So the turnout's down, but the people within the turnout wanting to continue is significantly a majority. And that gives the British Medical Association Resident Doctors Committee a mandate to continue industrial action. It's been something collectively that we've been working to manage the impact of. And I'm grateful to the consultants, the managers in our institutions, the leaders across the system who've been doing that. It's a collective effort to make sure that people aren't impacted as badly as they could be. Now, there's lots of positive noise being made today about there still are conversations and discussions which may avert any further industrial action, but it's worth noting that that's still in the mix. The second thing to draw out is there's emerging some, rightly, some further information about how the National Quality Board will work, how its strategy will be set, what the priorities within that strategy will be, and how they cascade across the NHS. And as a system, we should always focus on the quality of services that are provided to people, their carers and families, and whether they deliver good outcomes, are effective, and the experience is a positive one. Now, as part of that National Quality Board and National Quality Strategy, you'll have noticed that in the news there's lots of coverage that it's National Cancer Day tomorrow and the National Cancer Strategy will be launched. And one of the really positive things you may have seen is the number of positive stories that people have been providing around their experiences of cancer and the treatment and support that they've had. Some world-leading, beyond our imaginations, interventions, and then the basics around having somebody with you, a peer or a professional, who can provide you with support and sometimes banter to get you through to the next phase of your life. So that National Cancer Strategy will come out tomorrow. As part of the National Quality Board, there will be a number of national service frameworks, now called modern service frameworks, on areas like mental health, children's services, frailty, and so on. And they're an attempt to say, look, with whatever you do locally, which is within your gift, there are some standards and some ways of doing things that should be adopted because it's best practice. And those things will start to emerge, 3 in the next financial year, and then 6 in total are in the pipeline. That focus on quality and safety, I think, is much needed. And, you know, it goes back to the heart of why people are here in the first place, to deliver better outcomes, deliver effective services, and deliver a good experience for people who really need it and pay for it, actually. So that's something that we want to make sure happens. It is public money. We need to make the most of everything we do for the taxpayer. You'll see within the report that some of the quality interventions required because services don't always deliver what's required. And it's good to see the improvements in Bradford Teaching Hospitals Foundation Trust and its ratings of its maternity and neonatal services. Bradford's part of the National Review of Maternity Services. I know that the team have been, we haven't had any specific feedback, but the team are coming back to visit again. I can see Saj is on the call, but I know that everybody in the organisation and everybody in the system is open to hearing anything that needs to be heard about how the service could be better. Because I think the culture that we try and set here in West Yorkshire is that we're here to listen and engage. And when we think we've heard everything, it's time to stop and listen, but listen even harder to the experiences of people. The integrated quality improvement group that's looking at Leeds, following the issues that have been identified in Leeds around its maternity services, is continuing to meet, and NHS England chair that meeting. And the scrutiny and support for that organisation is significant. It is part of a national review itself that's been announced by the Secretary of State, but we don't yet have a chair for that review or the terms of reference agreed. But it's a really good example of, alongside the good things that we're doing around quality, there's a lot of things that we really need to be much better at, and we can only be better when we listen and we act. And that's why having, the founding principles of our system being about empathy for staff and patients, being evidence-based, being open, and dealing with the issues, not admiring the problem, doing something about it. Those things are critically important. The other thing just to mention then, since we last met, is the amount of positive progress that there's been on some of the broader pieces of work. And we'll get to hear a bit more about the work we're doing on healthy working life. And we'll get to hear a bit more, I'm sure, throughout the conversations around things like creative health. So we are in a space where those partnership pieces of work that go beyond the NHS and into the wider determinants are material and materially making a difference to people's lives. And that's why we're here. So hopefully people have had a chance to have a look at the report. Hopefully those updates are helpful. And the report really sets the context for the rest of the conversation. But if people want to ask any questions or pick up any points, very happy to take them.
Thank you very much, Rob. And I repeat Rob's invitation. Are there any questions or comments on Rob's report and the issues raised in it? I'm not seeing any indications at the moment, Rob. I think that's a bit of a first, isn't it, for these meetings?
That's very good.
Okay, but thank you. Thank you for the detail and consideration that's gone into that, as always. Okay, so I'll take us on then to the next item, which is patient and public voice, and I'll invite Paul to introduce this item. So over to you, Paul.
Thank you very much, Councillor Swift, and good afternoon, everybody. So my name is Paul Hemingway, and I'm Deputy Director for Communications and Involvement at the ICB. So today's item is specifically around a video, which essentially is linked to the Healthy Working Life programme, which will segue nicely into the item that's going to be presented by Duncan Cooper and Jennifer Connolly after this particular item. But one of the things I just wanted to point out before we share the video is, given Rob's really helpful update in relation to the partnership board update from his perspective, there's obviously quite a lot happening within the health and care landscape. But one of the things that we really need to make sure that is of paramount importance and that carries on and shines through within the work that we do at as a partnership and equally at the ICB is make sure that patient and public voice remains absolutely paramount in relation to everything that we continue to do. So I'm not necessarily going to go into the devil of the details specifically at today's meeting about how that will work in the new world, but there is a huge commitment from every organisation across West Yorkshire, from Health Watch organisations, VCSE organisations, local authorities, ICBs, and the emerging place provider partnerships and collaboratives, to make sure that what we do always goes back to the patient and make sure that what we do is in response to what we hear, and how we commission services and provide services will fundamentally continue to be built on that. So What I'm going to do now is I'm going to show a short video. This video is about 5-6 minutes long, and it links to the significance of the Healthy Working Life programme. So I'm not going to talk too much about the programme, particularly at this stage, but what I will say is that throughout the Healthy Working Life programme, insights, data, experience continues to really shine through from a patient public voice perspective. So please do watch the video next, and then we can answer any particular questions after, and that'll segue nicely into the paper that Jen and Duncan are going to present. So I'm just going to share this. I won't be a second.
So my name is Paul. I'm a flight attendant doing ultra long haul flights. So my initial concerns about continuing flying was at my worst point, I could only walk about 50 yards without becoming extremely breathless. And the first part of my job involves me getting from the crew base to the aircraft, which is like a 20-minute walk. And I would never have been able to do that. My second concern was that flying at altitude, you have a lower oxygen concentration in the air. And so I was concerned then I wouldn't be able to perform my duties, especially for such a long flight over such wide areas of water where there would be nowhere to divert to in an emergency. So I was quite anxious about that. So after I had my initial stents, I was referred to the cardiac rehab team, and a physiotherapist did a walk test. Unfortunately, I had to stop doing the walk test because my oxygen levels were really low, and she was concerned about it. So Dr. Rasool got me in to do a further angioplasty. And from then, I had another assessment from the physio, who then referred me onto the cardiac rehab gym. So once I started at the gym, suddenly I was getting all this input. I had my own physio, I had my own nurse, I had my own occupational therapist, and they were all in constant contact. They were calling me. I obviously had their number in case I needed to contact them. But I also went to the gym twice a week. So it was really good because I was working in a safe environment with a group of people that are all in the same situation as me. So there was no pressure, there was just support, really. And when I first started, I didn't do anything. Before I started at the gym, I was only going out like twice a day with the dog for 10 minutes, just for an idle stroll, because I daren't do any more because I was worried. Once I started going to the gym, because it was safe and there were people there to help, my confidence grew and I pushed myself a little bit more and a little bit more each week. And the results were that 3 months ago, I didn't even want to go back to work. I never thought I'd go back to work. Certainly never thought I'd go back flying. Whereas now I'm in a position that I know I can do it. So I'm not concerned and I really, really want to go back to work. And that's the big difference. The whole cardiac team has been fantastic. All the angioplasty nurses were brilliant. One of them told me that I was a bit chubby, which motivated me to lose weight. So everything's been positive, but I can't emphasise how good the rehab team have been. So fingers crossed. I'll pass my aviation medical next week and then back to the skies in February.
but that gives you a really good example of how the work that we do across the partnership has a real impact on people within West Yorkshire. So I'll pause there, Councillor Swift.
Thanks very much, Paul. And thank you. It's really, really interesting video. Any immediate questions, comments, or observations before we move on to the broader working well item? Not initially. We'll just let Jen back in. I'll probably doing well with the next item. So, Paul, is there anything you want to sum up on that, or do you want me to move on to the next item?
No, I think we can move into the next item, Councillor Swift. As I say, it segues nicely into Jen's item.
Okay, so yes, so this is looking at the work, the connection between health and the local economy and the impacts of health on access to work. And I'm going to, yes, I'll hand over to Jen to introduce this item.
Thanks very much. Afternoon, everyone. My name's Jen Connolly. I'm Associate Director for Improving Population Health, and I have a joint appointment between the West Yorkshire Integrated Care Board and the West Yorkshire Combined Authority. You've all had the paper. It focuses within our work and health agenda. It focuses particularly on the work of the ICB-led Accelerator programme and the forthcoming Workwell programme. And I've got some slides to share, and my colleague Duncan is also joining to give a particular perspective from the Bradford place. So we'll take you through some slides and then really open up for wider questions after that. Just let me get this shared. So there's been a great deal of work in the health and growth space over the last couple of years, really. Building on the national publication of the white paper around Get Britain Working, there's been a number of programmes that have been launched across government through the DWP and through NHS England and DHSC. We've at West Yorkshire brought that all together under the Healthy Working Life Board. So we have an accelerator programme, a value of around 11 million over the last year. That was a one-year programme. We've got a trailblazer, which is the responsibility of the Combined Authority, a value of about 10 million. That was for 1 year originally and has been extended for a second. And we've got a programme called Connect to Work. That's over a 5-year period, and again the responsibility of the Combined Authority. But we can see that there's a real need to bring all of this work together, and we've done that through the Healthy Working Life agenda. That work has got 2 key objectives. It's really thinking about population health, so supporting residents with health barriers towards good work, but thinking about the population health outcomes and thinking about that link with work, about reducing people becoming economically inactive through the prevention and early intervention activities, including health activities that we can do to support people to prevent them falling out of work. The programme's got a number of kind of areas of work which you can see listed there, and we've established governance around that, which is our Healthy Working Life Board, and you can see some of our key members photographed there, which was our first meeting of that board back in July. That board met again last week, and if you want a fuller description of all of the activity that's going on across West Yorkshire in this regard, that meeting was in public, and the papers and the meeting could be viewed via the West Yorkshire Combined Authority website to get the full richness. I won't do it justice in the presentation today. A quick reminder on the Accelerator programme within all of that wider context. We had 11 million, which was the responsibility of the ICB over this financial year, and we allocated that as we do. Predominantly went through to places, and we set some kind of parameters around that and guidance on where we felt that was best used. We really wanted to think about the allocation of resource based on on the need rather than a kind of per head count. So we used our proportion of economically inactive due to long-term sickness to make those allocations. And we're really thinking about an outcomes-based model here. So we want to see those outcomes. We want to see people not falling into economic inactivity, or in some cases being brought out of economic inactivity into work and being supported through their kind of health interventions to do so. We really wanted to focus on work with the voluntary community and social enterprise sector, and really supporting us to reach people that we wouldn't otherwise reach. We wanted to be intelligence-led and use the data that we have to identify the cohorts that we know to be at greater risk. And we really wanted to think about the opportunity to scale where we knew there was good work already. So we've done some cross West Yorkshire work on vocational rehab and working with carers. So working with supporting employers to support carers in their workforce. We wanted to focus on reducing inequalities within this agenda, so thinking about some of those things up front, and we wanted to really think about the learning we could do collectively. So whilst there was decisions made through each of our place committees about the kind of key things and where they would fit locally, we also wanted to keep connecting and keep learning from each other. So those were just some of the principles of allocations that we made about a year ago now in setting up the accelerator programme within that wider context. And we've made good progress. We have the Healthy Working Life Board, and we have a programme board that supports that public board. We've got a comms toolkit supporting us, and we have a website with further case studies available, so you can go and Paul's just shown us a great example. There are other case studies available from across West Yorkshire if people want to go and have a little look there. We've got 60 interventions now live across West Yorkshire, supporting people in different ways. This is a complex kind of area of work. So we've got, we know that musculoskeletal, mental health, and cardiometabolic and diseases are important in this space and are things we need to consider. But we know that it's wrong to focus on single disease interventions, because often we're seeing people present with multiple conditions, and learning to support people with multiple long-term conditions is key for our approach more broadly. And through those interventions, we've had over 3,000 referrals into those, so we can see that there is clear demand for the offer that we have put together. We've brought together local leadership as well as the kind of West Yorkshire governance around this. We have brought together local leaders at place level to oversee that health and work agenda more broadly and the various interventions in that space. And we've also been able to get up and running some additional digital therapeutics, so different apps and things that people can use to help them access early intervention support to help them manage their own health conditions. In regards to data and evaluation, we've done an awful lot of work to support the different providers, and the providers are from all different sectors. We've enabled them to get the data flowing so that we can really start to understand what's working, interrogate that data to understand who's accessing our services, and to answer a bit of the puzzle that we didn't know at the start of this, which is how many people might we need to support through the activity that we deliver to get the outcomes that we want to see. So we really are testing that question of how many people would we need to see and support with some of this activity to avoid them from the decline that we don't want to see for anybody. That's the accelerator, and that has been a one-year programme. We have had no confirmation that any accelerator funding would be made available for a second year, but what we have been notified about is Workwell, and this is a related programme of activity that's been underway in about 15 ICBs across the country over the past sort of year, 15 months. This is now going to be rolled out across the country, and you can really see, you know, the programme detail aside, you can see the strategic intent that work and health is key focus for this joint relationship between local government and the NHS moving forward. And you can see there is real intent around this agenda. So we must be thinking about how we implement that across West Yorkshire. Getting into the detail of Workwell briefly, it's going to be rolled out to all ICBs. It is looking at, it's kind of a low intensity model. So some of the accelerator work has been higher intensity, and we've really focused on the services that can support people to make that change, or to support them to feel more confident in managing their own health condition, or get the clinical advice that they need to do so. This model is a biopsychosocial model that's based on health and work coaches that would then route you in to navigate some of those interventions that we are delivering through the accelerator. So it's more similar to a social prescribing type of model, and then rather than funding the interventions that we've been specifically funding with the accelerator funding this year. Workwell does look for multiple referral routes in, whether that be through GPs, employers, Job Centre Plus and VCSE offers as well. And again, it's really focusing on people, trying to identify people who are at risk of leaving work due to their health and prevent that from happening. Around Workwell, there are clear governance expectations. They talk about a Workwell partnership or partnerships, and we think we've got that in place through the Healthy Working Life governance that we've already got in place. So we don't want to set something up separate to that. And through the Healthy Working Life board last week, we've agreed that Workwell should become part of this Healthy Working Life family in West Yorkshire. And it does bring further investment. So the indicative amounts are shown there, noting that that is a lower value than we have had in the accelerator programme over the last 12 months. So in summary, the paper sets out the progress that we're making on the accelerator. The clear strategic intent continues, and we have had some real national recognition of the work that's been done in West Yorkshire. Our data has been used to inform some of the OBR modelling in this space, and over Christmas, the case study that you saw presented earlier got some national press attention. We're really learning from this accelerator work about the complexity of need that people are facing. So understanding mental health needs, the relationship with employers, wider social challenges, that really indicates the need for sort of longer and more flexible interventions. Over the last year, we've really strengthened the health and work governance, and the value of having that governance board, that board that's co-chaired by the Mayor and by Rob, has given us kind of the chance to get better at aligning. There's still further we can go with that, but the chance to get better at aligning all of these different programmes and interventions that have been coming through. I've mentioned that policy direction that's really clear through the 10-year plan and the strategic commissioning framework, and this work will need to continue in some way or another. There is an expectation that all ICBs address economic inactivity and integrate work, health and skills, so that's quite clear in the strategic documents. I've talked about the Workwell overview and the multi-year funding, and really that gives us a chance to pause and reflect on the work that we've done to date and where we can go forward, and just having that slightly longer financial time frame around this work I think is really positive at this stage. We must just note that whilst we've got loads to learn from the accelerator and we're really building on something very positive here, there is a shift in how we need to what's expected through Workwell, and so we can just take this chance to pause, reflect, and given the fact that the role of the ICB is changing so fundamentally as well, we need to think about how we kind of do that design work and get that right going forward. I'll pause there and ask Duncan to talk to you a little bit more about his reflections from leading this work in the Bradford place.
Okay, thanks, Jen. So I'll just introduce myself. I'm Duncan Cooper, and just to remove any doubt, because there's two Duncan Coopers that work for West Yorkshire ICB. I work for Bradford District and Place, and I'm Associate Director for Reducing Health Inequalities. So what I want to do is just give some reflections on how the work's gone in Bradford. I've been the SRO for Bradford for this work over the last year, set up the local steering group, and we've got lots and lots of learning and some real challenges for the future. Okay, next slide, please, Jen. So the first thing that we did in Bradford was to try and build on some of the existing good practice and networks that we've got. And before we really even got into the design stage, we had a really useful workshop. Had the ICB and NHS provider partners, had VCS Alliance and their leads there, and then also local authority reps as well that were obviously already linked into Employment West Yorkshire. And it's a really important discussion on what were going to be our principles to really take us through the work. And these were the things we came up with. I think probably the most important ones out of those were to develop the existing networks and services that we've got. And one of the good decisions I think we made was to commission a VCS lead provider organisation to really help corral the VCS sector. So we've got multiple VCS organisations working within the accelerator, and that organisation took that lead for us across the VCS sector. The other thing was around the top right there, in year one, we talked about centralised leadership rather than trying to put a centralised triage point together, because we only knew we had 12 months to implement this. Rather than setting up a very, very complicated initial triage point and hub, we thought, let's just get some of these services off the ground, see who we've got coming through and evaluate that in year one. The other thing was around addressing multimorbidity. So the guidance that we had talked a lot about mental health, talked about cardiovascular disease, but what all our providers, NHS and VCSE, came back with and said that we need a biopsychosocial approach. So a clinical model that also addresses people's mental health and well-being, but also takes account of the really difficult life circumstances and the multiple risks that people have got for ill health across Bradford, especially in the more deprived areas. And then I think the final one that I bring out from this slide is about that use of trusted settings. So NHS is the most trusted settings for some people, community organisations and community access routes are most trusted for others. So it's really important that we develop that for both treatment and for referral points in those settings. Next slide, please, Jen. Okay, so this is a one-pager of the services that we set up within pillars 1 and 2 of the accelerator. So the blue column is services available to people that fit the cohort in terms of at risk of work, out of work, or short-term sickness with long-term conditions. So we developed a range of interventions building on our vocational rehab services locally, looking at pathways to employment and how that was already working within the mental health world and with talking therapies, and then also our employment and pain service. So that's developed from our Rethinking Pain that already had modules of different elements of the sorts of support that people can get around long-term pain. And then in the right-hand side there, those are services available for NHS and social care staff in Bradford. So we had the enhanced talking therapy service, occupational health, additional occupational health support, and all of these have got, rather than just looking at the health needs of people, they've also got that work focus as well. And on top of this, later in the year, because the funding for digital therapeutics came a little bit later, we've developed some work around Key Active, which is around this physical activity app that our proactive care teams are using now. And then we've worked with primary care as well to use something called Get You Better, which is a 12-week course around MSK and handling pain. Okay, next slide, please. Okay, so what I wanted to do is just I've got 2 slides of data, one about activity and one about who's coming through the services. So the graph on the right really sort of demonstrates the journey we've had. So we found out about all this in Snowdome in Wakefield in December 2024. And then we got a steering group together, started to design services. We were told that we needed to mobilise by April, which was obviously very difficult. And as you see from the lines there, the dark blue lines, the numbers of people that were referred, that started to creep up slowly as services were mobilised through spring and early summer. And then we did a lot of promotion early in summer to try and get the services. We waited till that point when all the services were up and running so that we were able to refer people between different services if that service either didn't have capacity or they felt another service was more appropriate. And then by October, we had one of our occupational health services didn't get off the ground, but 7 out of the face-to-face interventions were live by October. What we found, you'll see a slight drop off there as we get to later in the year. Unfortunately, as we weren't able to get the year 2 funding for the accelerator, we have some money via Workwell, but we have a shortfall now because of the accelerator funding. Some of the services have had to start demobilising this year, which is a real shame, but we're determined to sort of learn from that evaluation and build that into our future plans. So in terms of the overall targets, we felt that we needed about 2,000 people to be referred to reach our target of 350 for Bradford. At the moment, we've got really good referral to conversion rates. About 70% of the people that are referred actually end up in the services that we mean them to. So it feels like there's a fairly good route for that at the moment, but we won't know until we do the final evaluation and sort of the proof will be in the pudding really in terms of whether what percentage of those people have remained in work. Okay, next slide. Thanks, Jen. So we've got the dashboard. A lot of pain and tears went into the dashboard, but it is there now and it's working. And there's a really, really good minimum set that's been collected about people's work status, their quality of life, and all types of demographic information as well. In Bradford, we've largely got a accelerator cohort that's reflective of our ethnic profile. We've got people, if you look at the bottom graph there, we've got about 45–50% of people within the most deprived 20% of England. So that about reflects the deprivation profile for Bradford. And you'll see from the graph in the middle about gender, women outnumber men by about 2 to 1. That also is probably the ratio they would expect if you look at the national figures on the numbers of adults that are out of work due to ill health. There's far more women than men. The main health conditions, I've got the graph down there in the right, depression and anxiety and MSK 1 and 3, all our occupational health services, unions, everyone is reporting that mental health and MSK are the key reasons for taking time off work. The no health condition more comes from the biopsychosocial model. These were people that had obvious long-term conditions and symptoms, but that work well enough to go to work as well. So we see that as a positive that they're coming through the model. But I think the thing to say is what everybody said and what all our services are saying, and it's coming back from the patients, is that the level of complexity and the amount of time that you need to spend with somebody to really support them in a holistic way back into the workplace, to also work with their employer on reasonable adjustments, it has been much higher than everybody expected. So short interventions have relatively limited impact, and it really, I suppose, supports the accelerator. There's quite a lot of money that's gone into the accelerator and quite a high level of intervention. So we have a 12-week service, and I think that is really, really needed to get that employer relationship. And what I'll do, I'll just read you out, because we get lots of really nice case studies coming back. I just want to read you a quote from somebody who went through the vocational rehab service. So this is what they said. They said the advice, including signposting to the union, was amazing. It stopped things going down a disciplinary route, and it made me feel empowered. The thick note was so supportive while I was waiting for the allied health professional report. It meant managers took my needs seriously and they amended my hours. I honestly couldn't have returned to work without that one-to-one guidance and support from the VR service. I feel like myself again. I've even auditioned for a play and I've even got the part. So there you go. It's 5 ways to wellbeing all in one quote there. So that's what it really means for people. It's about skills and it's about setting goals and it's about advocacy. Okay, last slide, I think, Jen. So this was sort of reflection, not just from me, from our group in Bradford, and also some of the things that came out of the West Yorkshire workshop we had a couple of weeks ago that Jen shared. I think we have the opportunity now to stand back and go, right, what do we want from a 3-year programme? What do we want to plan? I think the current amount of energy and innovation that's gone into year 1 has been amazing, but it's unsustainable. And we've probably got to think about the new ICB structures as well and give ourselves a bit of a 3-year time frame to evaluate and do this. So I think the first thing is we need a more coordinated triage and referral hub and time to build primary care pathways, a proper population health management and a local insight driven into the way that we define cohorts. I think we have time to do that now with Workwell, and that's what we need to do across West Yorkshire. I think one thing that is developed really well is this has been jointly led by the Combined Authority and ICB, and similarly at place level we've developed really strong relationships with our local authority colleagues as well about some of the personnel employer incentive schemes. And like, for example, we're working with referral pathways into Skills House in Bradford, and that's really complementary for the work and health sectors. I think thirdly, we need to think about what's the most efficient way of taking this forward in West Yorkshire. So Central West Yorkshire Strategic Commissioning Function, working directly with providers and provider collaboratives, is probably the model that we need to think about for the future. 5-place teams all doing their own data governance, contracting and evaluation isn't really the most efficient way to do it. So we really need to think that through for a 3-year programme. The local support obviously still needs to be there from the integrated teams and the ICBs, and that'll be absolutely essential for those local relationships. And then fourthly, I think one of the things that we've spoken about is we keep commissioning bespoke services with short-term budgets. And perhaps what we need to do is about thinking about strategically shifting that whole health and employment sectors to thinking about health and work as a national good. And it's something that we have to do in conjunction the whole time. So the joint consensus statement on work and health, which Jen put in a paper, things like that are really, really important. So we can get away from this reliance on a few bespoke services that don't have that security of funding and really think about shifting the whole sector. So those were the main thoughts from me on the 3 years. I'll hand it back to you, Jen. I think you've got the last slide, haven't you?
Thank you. Really helpful and really insightful. Thank you, Duncan. Yeah, I've just pulled up the key recommendations from the paper, and I think leading on really well from what you've just said, we can see that the intent is there nationally, that this agenda isn't going anywhere, and we want to keep building on the momentum and the learning that we've developed over the last year. While that programme itself and is changing shape, and we should take this moment to pause, reflect, think about what we've learned and how we want to go ahead moving forward, building on the principles Duncan's set out. We do recognise that we need the whole of this partnership involved in supporting that as we move forward. And we think that there's more we can do if we think about all services against this framework of work and health. And the paper details the consensus statement actions that I think we could do well to consider against services. How are we having that conversation about work and health, and how are we thinking about that through all we're doing, not just seeing this as a kind of a programme that sits aside. So that leads us to the 2 key recommendations that we've put in the paper, but we'll stop there and welcome questions. Thank you.
Thank you very much, Jen and Duncan. There's a lot in that and a lot of good detail in there. I think what strikes me looking at your presentation as against the recommendations, I think the detailed recommendations about things health can do are fine and we should adopt those. But I think it's important that we don't lose sight of the bigger issues. And I think in the summary of Duncan's slide, I think perhaps the one thing I found concerning, I noticed colleagues picked that up in the chat, is that it seemed like the key message from the accelerator and the early work is about that issue about complexity and lengthy interventions. And yet I think what I picked up from your presentation, Jen, was that initially the shift in terms of the government funding is the opposite way, with more emphasis on short-term interventions when the evidence is that perhaps those are not the most effective. So I think we need to flag that up and capture that in our recommendations. Obviously, perhaps something particularly that the mayor's in a position to lobby on as well. But I think we ought to make it clear that we recognise and want to learn from that, and we need government to recognise that. I do find this focus on kind of 1- and 2-year funded programmes very, very worrying, because I do question how you can demonstrate it. But if then the bits of learning that does come out, then they're doing the opposite, then I think that's a significant worry. Rob.
Yeah, thank you. That was really good to see the detail again and to see the stuff from Bradford, Duncan. And I was just struck, Duncan, that 9% of the referrals were people with long COVID, RME, or chronic fatigue syndrome. And do we know if that's a pattern that's replicated across all places? Because it's we don't see those levels of proportion of activity on many programs. It's not something that comes up in that way, and if it's that significant or substantial, it might be worth paying a bit of attention to.
Yeah, I think that's a good point. I mean, part of the reason why that shows up quite a lot in the Bradford data set is that the vocational rehab services it has developed out of the long COVID pathway from about 3 or 4 years ago. So it's sort of developed into like multifunction systemic support for people with long-term conditions. So I don't know exactly whether that's replicated, but I certainly, if you look at the percentages of people now that have got 2, 3, 4, 5, 6 multiple long-term conditions and are still trying to hold down a job or are long-term carers themselves, it's really, really worrying. I think that, and particularly with the inequalities angles, people are reaching out those levels of need 10 or 15 years earlier in inner city and deprived areas as well. So it's something that we will really have a look at the end and see whether it's replicated across, but I would imagine it probably is.
Thanks, Duncan. Louise?
Thank you, and thank you for the report. I just want to say we were really fortunate enough to be part of this at the place level, from a independent social care point of view, from Bradford Care Association, and at place we were able to identify, and this obviously goes across the region and nationally, that social care often has really limited access to occupational health therapies, mental health therapies, etc. So we were able to put some direct interventions in place, and they've been an absolute success. Mental health therapies have been completely oversubscribed, and we've been able to, maintain people within employment or prevent them going off sick or arrange for them to come back into work much swifter. So I absolutely support that. We've seen firsthand the benefit that this has made to the sector, and it's something that we'd really like to expand upon and develop further. And so fully support this and really keen to get involved, both obviously at Bradford Place, but also across West Yorkshire with the other care associations, because I think there's a huge opportunity to support our sector, our workforce, but also in turn the people that we're supporting out in the communities as well.
Thank you. Should take a number of comments and then come back. I'll ask Jen and Duncan to come back on them. Anthony?
Thanks very much, Tim. Interesting presentation. The historical challenges of young people, and particularly young men and NEETs, has had very little success over years. And I just wondered what the focus was around younger people, because in terms of socioeconomics and the challenges that those bring to economies, and particularly to inner cities like Leeds, I wondered if there was anything around that area or any focus that you were intending going forward. Thank you very much.
Thanks. Let's take Tabitha next. Yeah.
Thank you, Chair. Thank you for the presentation, Jen and Duncan. It's very encouraging. Just a few comments on the referrals that came through for the Bradford Accelerator. It's in some ways encouraging that a vast majority of the referrals are people in work or people off sick. And I think that's encouraging because it kind of hits into all the early intervention and prevention agenda to help people stay in work. So that was encouraging to see. And my voice with the others who've spoken about this kind of being rolled out more generally across West Yorkshire with funding behind it would be really welcome. And the question I have is around how the accelerator program weaves into organizational programs around supporting people in work, because some organizations have the capacity to do more of it and others less of it. But how is that going to come together with large organizations who are already doing some of this, if not all of it? How does that weave together? That's the question.
Thank you. I'll bring Ian in and then come back to you, Jen and Duncan. Okay, Ian?
Yeah, thanks, Jen and Duncan. A really good presentation and really good work. And I think this has been a real success over the last 12 months. We spoke previously about how we might want to work together as a partnership, and I think this is a really strong example of where partners have come together to do this work. And I do want to mention the VCSE as well, the voluntary sector, who I know have played a huge role in delivery around this, which maybe didn't get as much focus in the presentation, but really important work there as well. I guess I wanted to come back to Councillor Swift's question around the funding, and it's 12 months funding is problematic generally. I think for a program like this, where it feels like it's just starting to get moving, and then we're having to look at stopping the funding because of the 12 months envelope is really frustrating. And I know there's conversations happening with NHS England and nationally to influence that. I just wondered whether you could say a little bit more about the evidence base and the evaluation that we're doing alongside this, and when we might be able to receive some of the outputs for that, so we can, strengthen our case upwards and maybe look at whether we want to do anything locally. Thanks.
Thanks very much, everyone. Sorry, Councillor Swift, shall I? Yeah, lovely. If I kick off, Duncan, but if you want to supplement with anything, please do. Really well made points across the board there. Louise, that relationship with the workforce, and that we had a dedicated focus on our health and social care workforce on this, and really Duncan's highlighted some of the interventions in Bradford, but that was the same across the board. So we knew that supporting our own workforce in this was really important. There's some really interesting learning that's come out of that across West Yorkshire, and linking it to Tabitha's point, there's some really good work being done by the bigger employers, but they can also have challenge in that respect, where they've got, they may have more services offered, but if that's not also aligned with kind of policy change and cultural support, and how that's delivered is really important. And that's something that we're learning from this work, where some of our SMEs can be really responsive and really able to support people on an individual basis, that when big organisations have key policies in place that are implemented by line managers in a particular way, may not fully support the individual at the moment they need it and in the way they need it, whereas some of the SMEs have been able to kind of do that in a different way. So there's learning coming out of what we're doing there. So just picking up on both of those points. I think linked to that, I'll come back to Anthony's point about younger people in a moment, but linked to that and linked to the funding question, there's something about how we continue this type of work without it being a dedicated programme budget, because as we can see, that comes and goes, that fluctuates over time, and it often comes with quite dedicated must be done like this sort of, or at least there's quite a kind of there's more directive guidance on how we could best do that, and whilst that's based on national evidence, we've got a real opportunity here to learn from the West Yorkshire evidence and what's been working here. So I'd really encourage us to think about how we get this into all of our work and into the organisations around this table way of doing things, rather than seeing it just as a programme that kind of can supplement that. In terms of the national, the youth question that Anthony raised, we're absolutely recognising that, and that is part of the wider healthy working life agenda. Our Mayor Tracy Brabin's part of the national review that's underway around this, and it's part of what we're really focusing on through some of the trailblazer activity, for example, through the local authorities and the employment support that they offer as well. So absolutely, I've just not particularly focused on it for the purposes of this. As I say, that Healthy Working Life Board available publicly, and the papers attached to that, we can probably put that in the chat, because there was a specific item on that at last Thursday's meeting, so more detail in there. And then coming back to Ian's point about the funding, the evidence base, how we're evaluating that, we are developing a West Yorkshire evaluation that will have a final report by the end of March, because that's the end of the programme, though we know activity and learning will continue. We're also feeding into a national evaluation that's been done, commissioned by NHS England. That won't report for another year or two, because they want to look at the data over time. So because we've been clear on how we collect the data, and we've got a minimum data set that's been agreed with NHS England, we will be able to look at people's outcomes in terms of their employment outcomes over a longer period of time. So we will continue to learn from that, and the national report will focus on that longer term, but we will have we'll have a West Yorkshire evaluation report available at the end of this programme as well. Duncan, anything you wanted to add on that? Sorry.
A couple of things. Yeah, no, I can't beat that. I think that just on Louise's point, I think that the informal care network, by carers as well, is really important. We didn't have time to go through everything today, but there's a West Yorkshire-wide bit of work that all the carers representative organisations across West Yorkshire are part of as well, to ensure that group of people that number tens of thousands have got information and know about healthy working life as well. So I think that's a really important one. It's been mentioned already, but sort of going back to Tabitha's point about large and small organisations, if we do have this insecure funding, and sometimes there's a huge pressure if you get funding to get that right to the front line straight away to support people, rather than thinking about the bigger prize, which is a whole organisational development approach. And it's more difficult putting money into OD posts sometimes, where you can't see, the tangible action. But I think we need to sort of hold our nerve there and develop a really big OD program, because one of the things that we did find was that there's variation by place on things like, getting workforce going. Leeds were more successful than Bradford on that. They already had a fairly well established workforce hub for NHS employees. We didn't have that in Bradford, and it was much more difficult getting those things off the ground. They just took longer, and people had to get used to things. So I think equally, ironing out that variation across West Yorkshire with really important things like that is important. And similarly with digital hubs as well, different areas have got a different sort of baseline of knowledge about that as well. So that's something that the ICB can really lead on. And just to answer Anthony's point, we did set up a specific pathways to employment service for young people with mental health issues and neurodiversity and learning difficulties as well. So there was something bespoke there, but I think more for young men that very often don't come forward. I would see that the sort of Employment West Yorkshire and the pathways to employment, reaching out as the way to really sort of target those areas. We've commissioned some of the local community anchors in Bradford to develop local networks for that, to hopefully reach out and find people that just don't sort of seldom heard and don't get into that sort of support. So there is some work going on there, but we can certainly develop it more. And then finally, I think what everybody's appreciating is that this is quite complex, and somebody put something in the chat about 18-month interventions. With Workwell, we have talked to Leeds across the country, and there does seem to be, although there seems to be quite a strict manual of what you have to do with Workwell, there seemed to be, like in West Midlands, I met the lead for Workwell in West Midlands, and she said they were able to have a tiered approach. So there was some quite rapid interventions, but they were able to put some emphasis and some funding into longer term interventions as well. So we've just got to try and make sure that our evaluation drives that, and we can do that as we go forward.
Thank you. So I'll take another round of comments, if that's okay, starting with Philip.
Yeah, thank you. Philip Marshall, Director of Workforce and Organisational Development at the Yorkshire Teaching Trust. I just wanted to say thank you for the board for showcasing the work, for the example. That was a nice segue into this session, and the experience of Paul, the cardiac rehabilitation team, multidisciplinary team here at the Trust. We've got a lot to be proud of with that team. On a personal basis, I've not long since shadowed that team and spent a session in their outpatient clinic, and I just see a really compassionate, humble approach to improving the care of our patients, and it's really aligned is the work that they do with the Economic Accelerator. So it would be wrong of me not to publicly say thank you to that team, but also for showcasing this today. And in the Wakefield place, we are absolutely heavily involved in the work of the Economic Accelerator. And I agree, there is a challenge about how we mainstream that beyond the funded project as part of our anchor institution responsibility. But yeah, thank you for that session. It was really good.
Thank you. Pip.
Yeah, thank you so much. It's really good, isn't it? And really appreciate you, Ian, kind of pointing out the contribution of the third sector in all of this. So, for example, really good, Duncan, that you flagged the work that the Health and Care Academy in Leeds did, but that was partly because it was able to use third sector capacity. And I think all of this, I think we're all recognising, aren't we, that there's so much added social value and return on investment for working on this. But we absolutely, as a system, need to think how money can flow and be most effectively used. So really important that we think about those issues around longer term funding, but also how we ensure that if money's coming into a system, it can be released as quickly as possible so we can start building the impact and evidence of that. And Jen, I know you and I have had some kind of conversations because I think there's some really good examples in all of this about where that has happened. So, for example, that Health and Care Academy example in Leeds, but also some other examples of where actually money's been kind of stuck in bits of the system because it was coming from WICA to local authority out to the third sector or whatever. And if we can be really brave and bold in the future and think how we release funding more quickly and actually hold resource differently, then we could just do so much more. And particularly because one of the interesting things I learned this week is that nationally we've got much higher sick rates than other comparable countries, and so there's I'm sure so much more we can do, and the added value of improving health and care workforce is a double value too. Thank you.
Thank you. Rob?
I don't know if Councillor Hinchcliffe wanted to come in or if she's covered it in the chat for me.
I'll just showing off. I've put it in the chat.
Hey, it's worth it though, that one.
But it's short for people who can't see the chat.
I just saying that Bradford has got very positive NEAT figures this year, so it's the lowest it's been since 2013, and it's well below the national average. So there's stuff going right there. I think that the challenge is after that, how do we get them into good income-paying jobs? And that's where the combined authority come in particularly, and making sure we have the inward investment that we need.
I guess that would sort of just struck me, Chair, that we've got a number of example, really good collaboration and partnership at all levels. And the great thing about these sorts of conversations is you get to see some of the detail that you're not aware of because things are happening, you know, at neighbourhood level or institutional level. And because of the financial distress that there is in the system, we've been relying on national funding, haven't we, to do things like this. And when the funding changes, then we have a direct response to that linked to the funding. I'm just wondering how we get into a position with multi-year planning, where the combined authority, the councils and the ICB can say, look, we mainstream this. I think people talked about how do we mainstream this. Philip talked about, you know, his cardiac rehab team. Well, they existed before, didn't they? You know, how do we mainstream this work in a planful way, which means it's part of the work that we do. And if there's a little bit of resource, which is a minuscule proportion of everything that we spend that's required to facilitate that, then we can make it available. Those amounts are very difficult when people in councils and NHS organisations are making very difficult decisions about what they can and can't fund. So if we can do it in the medium term together, because this is a strategic priority, we might not be buffeted so much by some of the national issues. And as people were talking, I was thinking about, well, Leeds Health and Care Academy wasn't a national requirement. The digital hub wasn't a national requirement. It was people decided together that we should invest in that. So as we develop our multi-year plans, one of the actions might be, how do we take the learning from this and plan for it as part of all of our future work?
Thanks, Rob. Really important point. Jen, anything you want to come back on the last comments?
No, I think they're all really helpful comments that kind of support the key questions that we're asking ourselves at the moment. So thank you.
Thank you. So thank you very much, Echo, and thanks for giving. That was that was a really good presentation from both of you, and the context of the case study from Paul was really helpful as well. So I think we're happy to endorse the recommendations, but I'd like us, if we can, just to add in, say, reference back to those key points in what I think was the penultimate slide from Duncan about the kind of complexity issue, and make sure we're flagging that up. And I think it's something about how we capture Rob's point then about understanding and starting to think about the ways in which this can be built into future multi-year settlements rather than just rely on there. I think that's probably one to go back to the board to steer back into future budget and planning conversations. But again, we can capture that in the minutes. That would be good. Is there anything else on that? Are people happy with that as a summary of the discussion we've had? As always, I'll just drop in my phone then if anybody heard a bang. In that case, I think that brings us on to any other business. I've not seen any. Does anybody have any burning issues they've not had a chance to say, given we're half an hour ahead of time, which is unusual? And I ask people just to note the work plan that's there, and that we have a draft date for the next meeting of Tuesday the 14th of April. I think that's intended to be in person, but we've not finalised the venue yet. Hopefully we can confirm that very shortly. And other than that, thank you everybody for your contributions this afternoon, and wish you all a pleasant and valuable rest of the day. Thank you.